Two left and right gonadal arteries. That's it, we're done. In male, they supply testes. In female, they supply ovaries. Good? So they're known as gonadal because you don't have to associate gender with it. In female, they're known as testicular arteries. Gonadal arteries in men are known as testicular as in female. In female, they're known as ovarian arteries. Good? Okay, so ovarian artery in female, testicular arteries in men, but they're known as gonad or gonadal arteries. Okay. Good, good, good. And their job is to supply the appropriate organ, and you know that, so I don't have to spend time on that.
Where does the umbilical artery come from?
In females, that come from internal. Yeah. We're getting there. We'll get there right now. Okay, so now the abdominal aorta. Okay, guys, calm down, calm down, calm down. Girls, calm down. Yes, thank you for question, because I'm being distracted right now. Yeah.
The most commonly occluded artery that's noted was
In the abdomen only, superior mesenteric.
superior mesenteric.
SMA. But that's only the abdomen, not the entire body. Only in the abdomen.
Okay.
Yeah, not in the entire body. Yeah? Okay, guys. Now, abdominal aorta will eventually branch into two terminal branches. It will become two common iliac arteries. Common iliac. Common iliac arteries. Left and right. Two common iliac arteries. Left common iliac, right common iliac. Good? Okay. Now, the next thing is, yeah, that's good. The common iliac will split into two. Will divide into two. Internal, if it's common, that means it always, whenever you hear this term common what? It must be having more branches that has the same name. So it has a common trunk. Okay, so if it's common iliac will split into internal iliac and external. Internal and external. So this is internal. And then external. We're almost done. The only thing we have left is hips and the lower extremities. Okay. Knees, thighs, and legs. What artery supplies them? So we're almost done. All right. So internal iliac supplies the pelvis. 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 External iliac, extremities. Lower extremities. Legs, thighs, ankles, hip joint. But just for now, internal iliac. So internal iliac supplies what? The pelvis. The major branches of them are superior gluteal, inferior gluteal arteries. So gluteal arteries. Gluteal arteries. So internal iliac. Internal iliac gives you branches. At least two branches are known as gluteal, superior and inferior gluteal artery. Umbilical artery. Umbilical artery. Another branch, vesicular artery, meaning supplying the bladder. Okay? So, in female, vaginal artery. There's one more branch known as pudendal. That's important. Let's write that down. Pudendal artery is actually very important. That's one of the branches of internal iliac. P-U-D-E-N-D-A-L, I think. Yeah, could be correct. I meant to say I could be wrong, but I said I could be correct. Pudendal. Pudendal artery supplies mostly external genitalia, not internal. See, pelvis is internal structure. Perineum is external genital structures. Okay, so pudendal mostly supplies the external structure of the pelvis. like scrotum, right? Like labia in females, skin of the genital area. So very good. Yeah, external inner canal, not internal. Good. So pudendal, umbilical. That's U, not A. Vesicular. Okay. So these are some arteries, and then gluteal. These are branches. So all branches to pelvis and perineum comes from who? Internal ilia. Internal ilia. Okay, so uterus, for example, is supplied with umbilical and vaginal artery, ovarian arteries. The only artery of the pelvis that doesn't come from internal iliac is which one? That exception. There's only one artery or pair of arteries of the pelvis that don't come from internal iliac. It's not a branch of internal iliac. That exception is always tested. Gonadal arteries. Testicular or ovarian. Where they come from? Aorta directly. Abdominal aorta directly. Remember that? So this G, gonadal artery. They still supply pelvis, pelvic structures. Testes are pelvic structure or perineal structure in men. Ovaries are in the pelvis. They're supplied by gonadal arteries. Yeah.
Would this be in reference to fetal development or
Adult. This is an adult.
development?
Yeah. This is an adult. Okay. External iliac. Now we're done with internal iliac. So
What about the bladder?
vesicular artery. Vesicular artery. It has superior, inferior, and middle. But we're not going to go too much in detail. So vesicular, vesicle, that talks about the bladder. Am I going too fast, guys? Okay, let's continue with. Uh-oh. Let us do that. Now, external iliac artery will continue and will become. I heard somebody. Very good. It will become femoral artery. And the femoral artery will split and it gives you branches. What would you call those? Before it's split into branches, femoral, it reaches just behind the knee area. That area is known as. Very good. Popliteal artery. It will be just in that area. That's what it will be called. In that area, it's very common to aneurysm and atherosclerosis in the lower extremities, and you can feel it. You can feel the pulse. So make sure you know that area. Popliteal area. The artery there is popliteal artery. Okay. Below that, just when it reaches the knee, just in the beginning of the knee, it splits into two branches. What are the branches? Very good. Tibial artery and fibular. Very good. Or peroneal, fibule. Again, just like in the arm, radius and ulna, same thing. It goes along the bones. But tibial will give you anterior tibial artery and posterior tibial artery. Okay, so tibial will split into two. Give you anterior branch and posterior. But below that is not important because we're not going to go into extreme little details. As long as you know, external carotid becomes femoral, become popliteal, and then it will become tibial and fibular. Tibial will have the anterior branch and posterior branch. Anterior part of the leg is by anterior branch, posterior by posterior branch. And fibular, lateral aspect. Fibula is your lateral bone, correct? When you're standing in anatomical position, you have two bones in your legs, tibia and fibula. Tibia is the big one. Fibula is the small, thin one on the lateral side. On the medial side is a big bone, tibia. On the lateral side, fibula. And arteries that goes along each of them gets the same name. Okay? So now, muscles on the front of your leg, anterior compartment, what should they do? Very good. Dorsiflex. Put your foot upward. Bring it up. That's dorsiflexion. So look, if you have something attached on the front of you, if you have a tape that's attached on the front of your leg or shin, and it goes all the way and attaches to your foot, and when you pull on it, are you going to bring your foot up or down? Up. Makes sense. So the anterior compartment raises your ankle joint or your toe. Okay, so that's dorsiflexion. But if there's a muscle on the back, your calf muscles, and they're attached to your foot, and when you pull on it, what do you think it would do? Push your foot down. That's plantar flexion. So that's what they do. So appropriate terms should be okay. Dorsiflexion is affected by anterior tibial artery stroke or blockage. Sorry, not stroke anymore. That's not the brain. And then posterior tibial artery will lead to plantar flexion defect. You cannot do it in that sense. So in essence, foot drop. You can have a foot drop. Okay. Okay, so we're done with anatomy of these blood vessels. So these basic blood vessels you should know. Okay, so these are major branches. It's a good idea to know them. Know their name. Just know in general what part of the body it supplies. In general, what part of the body it supplies. So for example, knee joint is supplied by who? Popliteal. Hip joint is supplied by who? External iliac. And the two gluteals. Okay, so anyways, ankle joint by tibial. Anterior and posterior tibial artery. So you will know that. Okay, good. We're done with this. Let's go on to, maybe I should say, you guys want this or not? I'll just give it to Ramshai regardless, so she can email it to you guys. You can delete it if you don't want it. If you want, keep it. Okay. There are some processes that happen within blood vessels. Let's go to physiology. Now you know, before we go to physiology, you know the layers of blood vessels. Media, externa, intima, correct? Let's review this quickly. I'm not going to write because you know that. We covered those. Intima, is this the middle layer, external, internal, or middle layer? Intima. Internal, good. Is it thin or thick? Thin. What is it made of? Simple squamous epithelium or endothelium. Good job. Excellent. Done. What is its function? Maintaining blood viscosity. Blood viscosity. That was the only thing you have to know. Blood viscosity. But of course, to maintain blood viscosity, what do you need? Clotting factors. Thromboxane A2. Prostaglandins. Heparin. Antithrombin 3. Did you forget those? Good. They're all made by who? Endothelium to an extent, except clotting factor by liver, right? And clotting factor 8 by endothelium. So you got to know those specifics. So we're coming back to endothelium. Endothelium has a function. It maintains blood fluidity, not blood flow. Blood viscosity, thickness or thinness. Blood viscosity. Okay? Are you okay with that? Or do you have any question about endothelium? All blood vessels have endothelium. There is no single vessel in your body that has no endothelium. It's impossible. All blood vessel has endothelium, but not all blood vessels have media or external. They don't. All blood vessels have endothelium, endothelium, endothelium. As a matter of fact, capillaries, the smallest possible blood vessels, are only made of endothelium, correct? They're only made of endothelium for exchange purposes. So the major purpose of endothelium is maintaining blood viscosity. What is the second? Exchange. Exchange. Meaning you allow nutrients and waste product to go in and out of vessels into tissue. Obviously, waste product will come into blood vessels. Nutrient and oxygen will leave and exit and go into tissue. Is that okay? So we talked about all blood vessels are made of layers. Blood vessels are made of layers, and there are 3 layers. They're known as tunica, externa, going from outside, media, middle, interna, the innermost layer. The innermost layer is also known as endothelium. It's made of simple squamous epithelium. Its function is to maintain blood viscosity. by different factors, and allow exchange of nutrients and waste product. We're done. Okay. Mhm. All epithelium must be attached to something. All epithelium are attached to a sticky, thick, strong membrane. That's known as basement membrane, made of collagen type 4. All epithelium must be attached to basement membrane. That's 100%. Okay. All epithelium must be attached to basement membrane. All blood vessels must have basement membrane. All of them. So the layer between media and antenna is known as basement membrane. There's a barrier. Okay. So basement membrane. All right. Let's move on to the next one. Media. Media is the middle layer, correct? We talked about it, and you know. Media, middle. Media, muscle. What kind of muscle? Smooth. Okay, so now know that media is made of smooth muscle. Is smooth muscle in your control? No. It is under the involuntary control, right? It's not in your control. So on media, let's just do this. You know what? This is a blood vessel. If this is a blood vessel, what are you going to do? Okay, there you go. Who announces, "Here we go"? Do you hear that announcement on TV? Here we go. Who does that? You guys don't watch that? What was the last time you guys watched boxing? Oh, girl. Isn't boxing out of fashion now? Nobody watches it. Why is that?
What is that? Boxing?
Yeah.
I watch it.
My dad watches it.
But it doesn't exist anymore. There's no big games. Nobody cares.
Yeah, Floyd Mayweather.
Nobody cares.
American.
Yeah, but nobody cares anymore. MMA is replacing it.
Yeah, but we're waiting for American and Floyd Mayweather and Pacquiao fight.
Is it coming?
I'm waiting for Pacquiao to get knocked out. Sorry, Floyd Mayweather.
Yeah.
I can't stand him.
Well, let's see what happens. Okay, guys. Now, dark color, right? Okay. So endothelium is the green layer, and in the middle is this red layer called media. Now, media doesn't respond to you. You respond to media. Media should have a receptor on them. The receptor found on media are known as alpha 1, beta 2. Done. Alpha 1, beta 2. Muscarinic 3 is very rare. Therefore, all blood vessels are regulated by which system? We did this. Don't give me this strange look like you never heard of this before. There you go. Please speak up. Thank you. Appreciate it. I feel like I'm useful, when you guys respond. And sometimes when you're just like staring, you're like, uh-oh, what have I done? Blood vessel is mostly supplied by adrenergic neurons. And adrenergic neurons release what? Norepinephrine. And the receptor that norepinephrine attaches to and activates them are known as beta 1. Beta 1, beta 2, alpha 1, alpha 2. So almost always blood vessels, the dominant nervous system that regulates is sympathetic nervous system. 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 Okay, so adrenergic. Now, alpha 1 causes smooth muscle contraction. Please remember that. Alpha 1 causes smooth muscle contraction. Smooth muscle contraction. Alpha 1, when you stimulate alpha 1, the natural function of alpha 1, we're not talking pathology, we're talking normal physiology. Normal physiology. Okay, normal physiology is alpha 1 causes smooth muscle contraction. Wherever you find smooth muscle, anywhere in your body, alpha 1 will cause it to contract. Beta 2, relaxation. They do the opposite. Okay, so beta 2 activation stimulation leads to what? Smooth muscle relaxation. This is, if you memorize it that way or understand that way, your life becomes super easy. Then you say, where would you find beta 2? Where would you find alpha 1? The effect is easy. But what is your focus? Alpha 1 causes smooth muscle contraction. Alpha 1, smooth muscle contraction. So I hope you remember that. Remember when we did this? If you tie a blood vessel, that's smooth muscle contraction. Okay, so alpha 1 causes smooth muscle contraction. And beta has to be the opposite if you get confused. Alpha 1, tying something, constricting it, squeezing it, contraction. Alpha 1 causes smooth muscle contraction. Beta 2 causes smooth muscle relaxation. Are we okay? Beta 1 is only found on cardiac muscle, nowhere else. Beta 1, B1, only on cardiac muscle, so ignore it now. Alpha 2 is only found in the brain, so ignore it. Now when we come to alpha 1, beta 2, they're found where? Blood vessels or smooth muscle. Only smooth muscle. These are found on smooth muscles. Okay, so smooth muscle. Cardiac muscle, we're done. Smooth muscle, alpha 1, beta 2. Blood vessels are made of smooth muscle. So alpha 1, what does alpha 1 do? Contraction. Beta 2? Relaxation. Good. So now if you activate alpha 1, what would you do to blood vessels? Vasoconstriction. Excellent. If you stimulate alpha 1, it leads to vasoconstriction. If you stimulate beta 2, vasodilation. Good. So it depends where you find them. If you don't find any of them, then nothing would happen. Now beta 2, smooth muscle, is also found on bronchi, correct? Bronchi and bronchioles, uterus, pupil of your eyes. Okay, so you'll find these smooth muscles in those areas. But we'll go there. Okay, next thing. So one aspect of this physiology is that you should know receptors found on blood vessels. In blood vessels, do you remember when you talk about resistance? What is TPR? Total peripheral resistance. How do you determine total peripheral resistance? You can just use R, capital R, and say resistance in a single vessel will be the same thing as TPR. Okay? So if you want to measure resistance, what is the factor that you memorize, the most important factor that regulates resistance? 1 over radius to the 4th. Ignore the length, ignore the constant, ignore the viscosity of blood. Of course those are contributing, but we're not going to care for them because they don't contribute that much. This is what you memorize. So this radius is regulated by who? So radius, look at this vessel, the radius is small compared to this vessel, the radius is large. So blood vessels can go between these two states, dilation and constriction. Blood vessels can go between dilation and constriction. Dilate, constrict, dilate, constrict. Good? And that's the radius, or the diameter, right? What's the difference between diameter and radius? So this is the diameter. Half of the diameter is the radius. Good? All right. And the factor that regulates vasodilation and vasoconstriction is the diameter or radius. The diameter or radius. Okay. And who regulates that? Beta 2, alpha 1. And who activates these? Norepinephrine and epinephrine. So whatever activates them will cause vasodilation. If you express beta 2, will cause vasoconstriction if alpha 1 is found on those vessels. If you block them, the opposite would happen. Okay? So very simple and easy. Keep it straightforward. Are we okay with that? Okay. A good question. Let me ask you this. Let's ask this. I think this is on your final exam, not now. How much blood vessels should be decreased? I mean, the lumen of blood vessels should be narrowed by how much, what percentage in order for you to be symptomatic and have angina? 75, 70%, 75. Good? If I ask you that blood supply, so the left coronary artery was narrowed by 75%, what happens to blood flow? By how much?
25.
So now the choices I give you are different, are numbers. See if you can calculate it. I won't give you percentage. I'll give you factor by 1 factor,
So it would be 1 over.
by 2, by 3 factor, by 16, by 18, by 19, by 20, by 200, by 2000. By what factor would blood flow decrease? We'll do it.
It would be 1 over R24, and then you calculate that much.
Okay, so Rahaf is saying that we will calculate the resistance, right?
Yeah.
Or the radius in this case. Okay, so resistance is what? And what is blood flow? What's the formula for blood flow? How about this? What is the formula for resistance? Okay, so TPR, that should be TPR, or capital R equals 1 over radius to the 4th, correct? Now, blood flow is represented by Q. If you have, how would blood flow be affected by resistance? Increase or decrease? So the relationship between blood flow and resistance, let me just go this. So resistance is inversely related to, blood flow is related inversely to resistance or TPR. The more resistance you have, the least blood flow do you have, right? Does it make sense? Because it's vasoconstriction. And let's see if you can incorporate now. What is resistance equal to? Resistance is 1 over R to the 4th.
So you would flip that.
Good. This means 1 divided by 1 over R to the 4th. Whenever you have division, you flip it. So you can multiply this. So at the end, Q is directly proportional to R to the 4th. So maybe you should look into this formula. If you don't know how to derive it, memorize it. This is the relationship between radius and blood flow. This is the relationship between resistance and radius. You can also keep this in mind too. So Q equals 1 over resistance. But it's directly related to radius. The bigger the radius, the bigger the diameter of the artery, the more easier it is for blood to flow. So blood flow will increase. The bigger highway you have, 20 lanes, traffic is going to go faster and easier. If you're 1 lane, for example, 55, 3 lanes are blocked, there's only 1 lane, what happens? Traffic jam. Same thing. The larger the diameter of the blood vessels, the more flow you will have. So blood flow Q is directly related to radius, indirectly related to resistance. And resistance will be in an accident or something blocking that area or road. Okay, now tell me, what do you think? What would you do? So if I'm asking what is your blood flow, I'm telling you the artery is blocked 75%. The artery is blocked 75%. So what's blood flow? Or what factor is it decreased? Obviously it's not increased because there's blockage 75% of. Look, think about it this way. Sometimes we don't think we don't know, we do know. If this is the lumen, divide into 4. So 75% is 3/4, right? Isn't it? Okay. If it is, let's block that. So all of this is blocked. How much is left? 25%. So what's the radius now? It's 25% of the original. You know what people do? They put 75% radius. They think the radius is 75%, so they put, for example, so if you wanted the radius here, this is what people put, 3/4. That's not true. This is how much is blocked. What is left is 1/4. 1/4 to the 4th. Okay. So 4 to the 4th is what? 256, yeah. Good. So blood flow is decreased by how much? 256 times more. It's decreased by 256 times compared to normal. Right now, you have to just memorize it so it saves you time, because this is the cutoff value for symptomatic angina. If it was 50%, it'd be 1.5, and that would be 1/16th, right? So this is 1/16. By 16 factor, it's decreased. So it depends what you're given. Okay. All right. Okay, so you know how to regulate blood flow. Blood flow depends on diameter, the most important factor. Although you could say that blood flow is inversely related to resistance. And if you think about it, how do you define resistance? Well, resistance should be defined, look, if an artery is longer compared to short, which one will have more resistance? A longer artery or a short artery? Longer one. If you go in a tube that is from here, let's say you're going in a tube. Do you guys ever watch this news? There's like those tunnels dig between Mexican and Texan border.
Yeah.
Okay, so if you have a tube that's narrow, there's more it's longer, more resistance. You can suffocate yourself, kind of thing. Think about it that way. The longer the artery, so length, and then the thicker the blood, viscosity, and then there should be a constant. So all of these will lead to increased resistance. Okay, but we're not going to care for that as long as the blood flow depends on radius. Radius, radius, radius. Resistance depends on radius. Okay? Keep it simple. Vasodilation, vasoconstriction. The most important factor that regulates blood flow. And who does that? Norepinephrine. Alpha 1, alpha, beta 2. Those are the two receptors that will regulate. So that's one thing in terms of physiology. One more thing in physiology. So let's say this is a capillary. And capillary is porous, right? It's thin. Things can go in and out, correct? Okay. So there are some forces. Within the capillary, you should have you have proteins, right? Within capillary, what do you have? Albumin. Particles. The particles produce pressure. Particles produce their own pressure. Particles produce their own pressure, and that's known as oncotic pressure. Oncotic. Oncotic pressure. Oncotic pressure, you should say, equals particle pressure. Oncotic pressure is pressure produced by particles. Hydrostatic. Hydro means water or fluid, right? Pressure is pressure produced by fluid or water in this case. Okay, so there are factors we need to know. Okay, so that's the two pressures. Good. Let's see. Now you have particles within the capillary, so you will call it capillary oncotic pressure. So capillary oncotic pressure. So let's say OC, that's capillary oncotic pressure. O for oncotic, C for capillary. Good? You should also have a pressure, hydrostatic, H, capillary pressure, within the capillary. You have fluid within the capillary blood vessels, correct? This fluid or water will produce its own pressure. Then you have electrolytes or proteins or particles that will produce their own pressure. Good? And you have the space between cells. The space between cells and blood vessels known as interstitium. Interstitium. The space between cells, this space in green, the space between cells and blood vessel is known as interstitium. There is no direct tunnels or channels between cells and blood vessels. So a thing will leak and then it will diffuse into a cell. Interstitium. Okay. Now, so you have interstitial. Let's use blue. Interstitial. So you have hydrostatic pressure in the interstitium. And you have oncotic pressure in the interstitium. Because you also have particle and fluid within the interstitium. And we want to compare that. Okay? So, second thing, you know where you wrote hydrostatic pressure? Know that wherever you have hydrostatic pressure, it's going to push away from itself. It's going to push water away from itself. Hydrostatic pressure will push water away from itself. Hydrostatic pressure, memorize it. Hydrostatic pressure pushes fluid away, water away from itself. Oncotic draws water towards itself. Oncotic bring it to itself. Hydrostatic away from it. So let's say we have capillary, and then we have a cell, and then here the space interstitium. And this is capillary. This pressure will only matter because in capillaries, because only capillaries are leaky, things can go in and out. Okay. Let's say capillary hydrostatic pressure. Capillary hydrostatic pressure is 25 millimeters of mercury. Good? Okay? Capillary oncotic pressure, let's say, is 5 millimeters of mercury. Okay? You know what? I want to do something. Just move this to the side so I have more room. You guys probably hate me because you can't do that. You write it down, and then you're like, oh, I want to move it. Okay. Okay, so now we have measures: capillary oncotic, capillary hydrostatic pressure. Let's say interstitial pressure. Let's do that in blue. Oncotic interstitial pressure, let's say, is 10 millimeters of mercury. And then you have hydrostatic pressure in the interstitium, that is 5 millimeters of mercury. Okay? The best way is to give direction to these pressures. You know that. Oncotic pressure. How do you define oncotic pressure? Pressure produced by who? Particles, correct? Particles. So the more particle you have, it's not based on size. It's only on number. The more number you have, the more oncotic pressure. Okay, so the higher the number of particles within blood vessels or fluid, the higher the oncotic pressure. So write it down because these rules are very important. The higher the number of particles, the higher oncotic pressure. The lower the number of particles, the lower oncotic pressure. So there is a direct relationship between particles and oncotic pressure. Oncotic pressure depends on the number of particles. Oncotic pressure depends on the number of particles. Oncotic pressure depends on the number of particles. The greater the number of particles, the greater the pressure. The smaller the number of particles, the smaller the pressure. Good? Hydrostatic pressure depends on water. The more water you have, the more hydrostatic pressure you have. The less water you have, less hydrostatic pressure you have. Okay, let's put the two together. Isn't that like opposite? If you have more particle, obviously you have less fluid. If you have more fluid, obviously you have less particles, right? So if you have more, if oncotic pressure increases within capillary, what happens to hydrostatic? Should decrease, because it's perspective with each other. It's not absolute pressure, it's relationship in relation to what? So if you have more fluid, more hydrostatic, low oncotic. If you have more particles, less fluid, more oncotic pressure, less hydrostatic pressure. Good? They go hand in hand. All right, what's the direction of oncotic pressure?
Number of particles.
The direction. It is the number of particles. Towards itself. Oncotic pressure draws water towards itself. Oncotic pressure draws water, attracts water towards itself. Hydrostatic pushes water away. Hydrostatic pressure is outward. Oncotic is inward. Okay, so let me write it down. Oncotic is inward pressure. Hydrostatic is outward pressure. Good? Are we okay so far? All right. Capillary oncotic pressure. Is it going to draw water towards itself or push it away? So that means the direction of this pressure is water moving, because the only thing that can move now is water. That's what we're saying, right? So in this case, water will move towards the capillary. How about hydrostatic capillary pressure? Away. Change it to blue. How about oncotic interstitial pressure? Away from the capillary. How about interstitial hydrostatic pressure? Into the capillary. So always two pressure are in the same direction. So capillary hydrostatic pressure and oncotic interstitial pressure in the same direction. When pressure and things are in the same direction, what do? You add them, right? Because the direction is the same. They'll push fluid in the same direction. And let's do that. So look, we have 25 millimeters of mercury outward. Out. And then we have 10 more out of the capillary, correct? Is that okay? And let me color it for you so you can see. These are the pressure I'm talking about. This is outward, and then this red one is outward. The direction of this pressure is the same, so total pressure outward is what? 35. 35 millimeters of mercury pressure is pushing fluid out of the capillary. Good?
You mean?
Does that mean it's dilated and it's just...
No, it's nothing to do with it. Ignore that. We're not talking about vasodilation and constriction. This has nothing to do with that. It is simply telling you exchange. How does exchange happen in capillaries? What drives nutrients to go out and waste product to go in? You don't have a brain in this area that tells you do this, do that. It's simply pressures that drives exchange of nutrient and waste product. In capillaries, what drives the forces that drives absorption, filtration, is these pressures. Two pressures only, oncotic and hydrostatic pressure. There's only two pressures that regulates this exchange. Hydrostatic pressure and oncotic pressure. Good? So the pressure pushing fluid out or material out is 35. And let's go the pressure in. Pressure in. So look, the pressure in is in yellow. 5 and 5. That's not much. So the pressure pushing fluid inward. So this is 5 and 5. The total pressure in is 10. 10. Which pressure is greater? outward. So if there's 35 people pushing out and 10 people pushing in, overall, where are you going? Out. So overall, the net pressure would be 25 outward. The net pressure, 25 outward. Which means in this capillary, fluid are going to come out. So the net pressure of this case is only edema. Edema. Okay? So this is effusion, not infusion. So the overall effect of this pressure in this case, in this specific case, would be effusion. Okay, fluid leaking out. Now, do you know why it's called pleural effusion? Okay, effusion means leaking out. That means if you have block, let's just do this. Okay, let me erase this. I'll just erase the whole thing. So let's say this is a pulmonary artery. Pulmonary artery or pulmonary capillary, they will have the arterial end and they will have the venous end. Okay, so they will have these ends. It's the same vessel. One end is mostly arterial, the other one is venous end. Okay. In lungs, the arterial end is blue, and then the venous end should be, because you bring deoxygenated blood, and then slowly it acquires oxygen, and as you go towards the end, it becomes more oxygenated and red. Okay, so that's the idea, and what drives these forces, and nutrients and everything else. But anyhow, so fluid coming in, or blood coming in, will have high concentration of what? Carbon dioxide. Okay, carbon dioxide. And low pressure up, so high carbon dioxide. You know what, let me just put numbers, because they would help. Let's put numbers. Let's say 46. Okay? And the carbon dioxide in the arterial end is 40. Oxygen in the venous end, or the arterial end in this case, is, what do you think? 60. Or let's just say even 40 is okay. And then the oxygen on this end is 100. Okay? That's within the capillary. That's within the capillary. And let's say here is you have alveoli. Alveoli, or alveolus, which is an air sac, right? Within this air sac, do you have more oxygen or more carbon dioxide? Oxygen is 100. 100, so that's oxygen. And how about carbon dioxide? It's less than 40. Let's just say 36 for the sake of argument. So this end that's in contact with this alveolus. Now you have more carbon dioxide within the venous end. Yeah.
Are we supposed to take pictures of this, or do you guys not to?
No, you can take pictures. That's
Oh, we can record too?
Yeah.
Okay.
Yeah. Okay. Now, where would carbon dioxide go? From the venous arterial and from the blue area. You have more, 46, and here you have 36, so it's going to diffuse out. Oxygen is less in this end, so oxygen is going to come in. Eventually, it evens out, so no more oxygen. So the pressure differences tells you what happens at that level. So in lungs, in the arterial end, there will be infusion of oxygen and effusion of carbon dioxide. In the venous end, all of that will stop because there's more oxygen already accumulated and the carbon dioxide evens out. So, okay. Now let's apply this to fluid. Let's apply this to fluid. So I don't want to use colors for fluid. You know, just keep it simple. Let's apply this to pulmonary capillaries. For example, we talked about CHF, right? Left heart failure, we talked about that. So, and this is the alveoli or alveolus. So blood coming in, blood leaving. Good. What if there is a blood flow blockage right here from the left heart? What are the consequences of that? Okay, so now there's more pooling of blood. What happens to blood volume in these arteries or capillaries? Increase. So what happens to hydrostatic pressure? More fluid. Particle hasn't changed. Remember that. Particles depend on concentration, right? The number of particles didn't change at all. If anything, you have more fluid now. So hydrostatic pressure increased. Oncotic pressure, same. So I'll just put same. Now that's within the capillary. Within the interstitium, hydrostatic pressure, same. Oncotic pressure, same. Obviously, there's more pressure within the capillary, and it's hydrostatic. And what's the direction of hydrostatic pressure? Away. So it's going to allow fluid to leak. And this is what leads to pulmonary edema. Now, you might be given values. You will be given values, and you should be able to add and subtract and give me the net direction of blood flow or fluid flow. Same thing in the kidney. Two areas where you will usually get these kind of questions. The kidney, Bowman's capsule, or pulmonary capillaries, lungs.
So would this be the same scenario in the cardiac tamponade where between the pericardium and the cardium the fluid is leaking and it's there? Is it the same thing?
No, because in the pericardium there is damage. It is not obstruction. It's not necessarily hydrostatic pressure increases. So the pipe is leaking itself. You have a huge gap. Things just leak in. So it's a different scenario. Especially if it's bleeding. Remember, tamponade was bleeding into the cavity. Yeah. Here, there's no bleeding, there's nothing. It's just increased pressure. Okay, because there's obstruction to blood flow. The left heart cannot pump. If it can't pump, blood will pool in lungs. And if it happens in lungs, what happens? Capillary, pulmonary capillary hydrostatic pressure will increase. It will cause fluid to leak into lung spaces. It will cause pulmonary edema. Let me give you a case scenario. You tell me what happens. So, pulmonary capillary hydrostatic pressure is, let's say, 50. Pulmonary capillary oncotic pressure is 10. And then pulmonary interstitial, I should put I. Pulmonary interstitial pressure, hydrostatic, pulmonary interstitial pressure oncotic. So hydrostatic is, let's say, 20. And oncotic is, let's say, 5. Do you expect there to be pulmonary effusion, edema, or normal flow, or nothing, or absorption? So you decide. That's one case. That's scenario A. Let me give you scenario B. Pulmonary capillary hydrostatic pressure, pulmonary capillary oncotic pressure, pulmonary interstitial oncotic pressure, pulmonary interstitial hydrostatic pressure. 20, 10, 20, 10. And what happens in this case? Scenario B. Okay, so is there flow in A? What's the direction of flow? Outward. So that would lead to fluid in the extracellular spaces, correct? Outside of capillary. And what do you call that? Edema. If this is lungs, because it's pulmonary, so you can call it pulmonary edema or pulmonary effusion. It's effusion. So as long as you use the term pulmonary or alveolar, that's what, or plural, so you can use the term plural. Every time I do that, this is what happens. Let's take a break.